Good morning, everyone. My topic for today's presentation is secondary glaucoma. The contents of this presentation are lens-induced glaucoma, inflammatory glaucoma, steroid-induced glaucoma, ICE syndrome, glaucoma associated with intraocular tumors, post-surgical glaucoma. Coming to lens-induced glaucoma, it is classified on the basis of secondary angle closure glaucoma and secondary open angle glaucoma. Secondary angle closure consists of phacomorphic glaucoma, phacotopic glaucoma. Secondary open angle glaucoma consists of phacolytic glaucoma, lens particle glaucoma, and phacoantigenic glaucoma. Coming to lens induced secondary angle closure glaucoma. First, we will study about phacomorphic glaucoma. So, it is basically acute secondary angle closure glaucoma, which is caused by intumescent lens, that is swollen cataractous lens. In this, the swollen lens pushes the iris forward and obliterates the angle, and then leads to increased irido-lenticular contact and leads to pupillary block and iris bombay formation. The clinical presentation is symptoms are pain, rapidly progressive visual impairment, nausea and vomiting, and the signs are lid may be edematous, circumcorneal congestion, corneal edema, shallow anterior chamber, mid-dilated pupil, and intumescent cataractous lens. Coming to management, it is by medical treatment to control the IOP by IV mannitol, systemic acetazolamide, and beta blockers. To control the inflammation, we give topical steroids. Laser iridoplasty may be useful as a temporizing measure, and cataract extraction with implantation of PCIOL is the mainstay of treatment in this case. Coming to phacotopic glaucoma, it is subluxation or partial zonal dehiscence of lens, which may lead to lens-induced angle closure glaucoma. It can be of subtypes like congenital subluxation, as in ectopia lentis and syndromic associations, traumatic subluxations, spontaneous or consecutive subluxation, which occur due to intraocular disease causing mechanical stretching, and inflammatory disintegration or degeneration of nodules. Coming to mechanism of glaucoma in this case, pupillary block happens due to lens subluxation and dislocation in the AC and due to vitreous herniation, and peripheral anterior synecdoche formation may develop due to chronic IOP elevation. Coming to management, anti-glaucoma medical treatment is given, and hyposmotic agents, carbonic anhydrase inhibitors and beta blocker may be helpful in breaking the attack. Cycloplegics relieve the attack by dilating the pupil when the lens has subluxated in the pupil, and laser PI helps in providing a bypass to the aqueous in the presence of pupillary block. And final and ultimate management is surgical removal of the lens. Coming to lens-induced secondary open-angle glaucoma, we'll study about phacolytic glaucoma first. In phacolytic glaucoma, trabecular meshwork is clogged by lens proteins and macrophages which have been phagocytosed and other inflammatory debris. Then there is leakage of lens protein which occurs through the microscopic openings of the intact capsule in the hypermature or Morgagnian cataractous lens. Clinical features are features of acute congestive glaucoma. AC is deep. There may be pseudohypopyon due to uh, uh, as the aqueous may contain lens particles which settle down, and anterior chamber angle is open on gonioscopy. Coming to management, medical therapy to lower the IOP followed by surgical extraction of the mature or hypermature cataractus lens with PCIOL implantation is the ultimate management. Topical and oral steroids must be started postoperatively to reduce the inflammation. Now coming to lens particle glaucoma, uh, the pathogenesis is trabecular meshwork is blocked by the lens particle, which may occur due to lens particle left after ECC or after traumatic rupture of the lens capsule, and associated inflammatory response contributes to the development of glaucoma. Management is medical therapy to lower the IOP, irrigation aspiration of lens particle from the anterior chamber, and cycloplegic and topical steroid to control the inflammation. Coming to phacoantigenic glaucoma, it is basically an immune-mediated inflammatory glaucoma. It is an antigen-antibody reaction where antigen is the lens particle, which is caused by body's reaction to the exposed lens protein. It typically follows trauma or surgery that disrupts the lens capsule, allowing the lens material to leak into the eye. And the clinical features in the anterior segment are granulomatous anterior uveitis. The signs can be mutton fat capes and anterior chamber cells and flare, and elevated intraocular pressure, corneal edema from elevated IOP, and posterior synecdoche formation. Management is medical therapy to lower the IOP, treatment of iridocyclitis with steroid and cycloplegic. Irrigation and aspiration of lens matter from anterior chamber should always be done after proper control of inflammation. Coming to inflammatory glaucoma, it can be divided into two subtypes that can be non-specific inflammatory glaucoma and specific hypertensive uveitis. Non-specific inflammatory glaucoma is further divided into open angle and angle closure, and specific hypertensive uveitis is divided into Fuchs uveitis syndrome and glaucomatocyclitic crisis, also known as Posner-Scholzmann syndrome. Now coming to non-specific inflammatory glaucoma. Non-specific inflammatory glaucoma can further be divided into open angle and angle closure. First, we will be studying about open angle glaucoma. It can further be divided into acute open angle and chronic open angle. So, the mechanism of IOP rise in acute open angle is by trabecular clogging by inflammatory cells, exudates, and turbid aqueous humor. And there can be trabecular edema due to associated trabeculitis. And the third mechanism is prostaglandin-induced rise in IOP. The clinical features are features of acute iridocyclitis, raised IOP, open angle of anterior chamber. IOP returns to normal after the acute episode of inflammation. And the management is topical steroid and cycloplegic to treat the iridocyclitis and IOP lowering drugs. We should avoid giving miotics and prostaglandin analogs that they can aggravate the inflammation. Coming to chronic open angle glaucoma, the mechanism of IOP rise is chronic trabeculitis and trabecular scarring. The features are raised IOP, open angle on gonioscopy, no active inflammation, but there might be signs of previous episodes of uveitis, and glaucomatous disc changes and field changes may be noticeable. So the treatment is almost similar, IOP lowering drugs, and we have to avoid miotics and PG analogs as they may precipitate the inflammation. Medical treatment, if it fails, then we can proceed with trabeculectomy, and if that also fails, then the final management is cyclodestructive procedure. And steroid induced glaucoma may occur in some patients during the treatment of uveitis, and it needs to be considered as a differential diagnosis for open angle inflammatory glaucoma. And it is also important to note that IOP rise due to steroid requires a decrease in potency and frequency of steroids, or even the use of steroid sparing agents may be advised. Whereas if IOP is raised due to uncontrolled inflammation, the dose of steroid has to be increased. So it is very important to differentiate inflammatory glaucoma from steroid induced glaucoma. Coming to Grant syndrome, it is also a secondary open angle type of glaucoma, and the etiology is idiopathic or it may be associated with sarcoidosis, ankylosing spondylitis, and rheumatoid arthritis. Mechanism of glaucoma development is blockage of trabecular meshwork due to the inflammatory trabecular edema and blockage by inflammatory debris. The clinical features are bilateral rise in IOP, minimal signs of inflammation. Gonioscopy shows open angle with yellowish inflammatory deposit over the trabecular meshwork, and here we can see the yellow deposit over the trabecular meshwork, and then the treatment is topical antiglaucoma and topical steroids. Now coming to angle closure glaucoma of the non-specific variety, it can be with pupillary block or without pupillary block. So the mechanism of glaucoma development in pupillary block is their formation of 360-degree synecdoche or seclusio pupillae. And this leads to formation of iris bombay and appositional angle closure. And if it is not treated at this point, then peripheral anterior synecdoche develop and it can lead to synechial angle closure. The clinical features are raised IOP, seclusio pupillae, iris bombay formation, and shallow AC. Management prophylactic is with topical steroid and cycloplegic to prevent the synecdoche formation, and curative is medical therapy to lower the IOP, laser iridotomy, and surgical PI. Coming to without pupillary block, the mechanism of IOP development in this is it occurs due to organization of inflammatory debris in the angle, and this angle forms a fibrovascular membrane which on contraction pulls the iris over the trabeculum, and this leads to gradual and progressive synechial angle closure with eventual elevation of IOP. The clinical features are raised IOP, shallow anterior chamber, peripheral anterior synecdoche, and there might be inflammatory debris deposited over on gonioscopy. We can see that. Medical therapy management, medical therapy is to reduce the IOP, and surgical is trabeculectomy with metabolites or drainage implants. Coming to specific hypertensive uveitis, first we'll study about Fuchs uveitis syndrome. It is also known as Fuchs heterochromic uveitis syndrome. The presenting symptoms are gradual blurring of vision due to posterior subcapsular cataract and floaters and difference in colors of two eyes. So the signs are very important. The signs of Fuchs heterochromia uveitis are in cornea. We can see fine keratic precipitates over the endothelium. In anterior chamber, aqueous cells of less than 2 plus and aqueous flare may be noticeable. In iris, there is heterochromia iridis, diffuse stromal atrophy, which is moth-eaten appearance, And posterior pigment layer atrophy. Iris nodules may be seen along the pupillary border, known as Cope's nodule. Iris crystals may be seen, which are aggregation of immunoglobulins, also known as Russell bodies, and rubeosis iridis, irregular fragile vessels seen on iris. And also, there is an important sign known as Amsler sign, which is recurrent hyphema as a result of bleeding from these fragile vessels. Then in lens, there can be posterior subcapsular cataract formation, and secondary open angle glaucoma may develop due to trabecular sclerosis, constantly raised IOP, and on gonioscopy, we see open angle with twigs of neovascularization. Management of uveitis is typically uveitis in FUS is typically resistant to steroids, but posterior subtenon injection of long-acting steroid like triamcinolone may be useful in cases of annoying floaters. Management of glaucoma comprises of trabeculectomy with antimetabolites or drainage shunt, which stays as the mainstay of treatment, and pilocarpine and PG analog should be avoided as they may precipitate the attack. Now coming to glaucomatocyclitic crisis, also known as Poschner-Schwarzman syndrome. It is characterized by recurrent attack of unilateral acute rise of IOP. Both eyes may be involved at different times, but very rarely contemporaneously they are involved. And the cause of acute rise in IOP is presumed to be acute trabeculitis, which may be secondary to HSV, CMV, or Helicobacter pylori infection. And there is direct correlation between the elevated levels of prostaglandin E2 in the aqueous humor and the level of IOP has been found during acute attacks in glycomatic cyclitic crisis. And this condition typically affects young males much more than females, and 40% of whom are positive for HLA-BW54. The clinical features are presenting symptoms include mild discomfort, halos around the light, slight blurring of vision without any redness and pain. Signs, there are no signs of congestion, but the IOP is raised during the attacks. In cornea, we can see epithelial edema and KPs, anterior chamber few cells with minimal flare, and on gonioscopy, open angle with no PAS formation. Course is the recurrent attacks are unilateral, and the interval between the attacks become longer with passing time. And recurrent attacks can lead to damage of the trabecular meshwork, and it can further lead to development of chronic open angle glaucoma. The management of uveitis comprises of topical steroid and oral NSAIDs. And for management of glaucoma, we prescribe topical anti-glaucoma drugs and oral acetazolamide if IOP is raised. Coming to steroid-induced glaucoma, steroid-induced glaucoma is basically secondary open-angle glaucoma that develops as a result of elevated intraocular pressure following the use of corticosteroids, topical, periocular, intraocular, inhalational, systemic, or dermatological. It is due to increased resistance to aqueous outflow through the trabecular meshwork, and it can result in optic nerve damage and irreversible vision loss if not recognized early. Then theories of pathogenesis of steroid-induced glaucoma. There are three theories: glycosaminoglycan theory, endothelial cell theory, and prostaglandin theory. So first coming to glycosaminoglycan theory. In this theory, the corticosteroid inhibit the release of hydrolase, which lead to inability of glycosaminoglycan to depolymerize, and which lead to retention of water in the extracellular spaces, which can further block the trabecular spaces and lead to decrease in aqueous outflow. Coming to endothelial cell theory, normally the endothelial cells lining the trabecular meshwork, they act as phagocytes and they phagocytose the debris from the aqueous humor. But corticosteroids suppress this phagocytic activity of the endothelial cell and can lead to collection of debris in the trabecular meshwork and decrease the aqueous outflow. Now, prostaglandin theory. The prostaglandin E and F are known to increase the aqueous outflow facility, and as we all know, corticosteroids inhibit the prostaglandin synthesis and release, which can lead to decrease in aqueous outflow facility and increase in IOP. The risk factors are primary open angle glaucoma, family history of glaucoma, high myopia, diabetes mellitus, connective tissue disease, traumatic angle recession, adrenal hyperplasia, or neoplasia. The clinical features are: patient is usually asymptomatic, IOP is elevated, white painless eye, open and normal appearing angle on gonioscopy, optic disc cupping, visual field defect in long-standing cases. The management consists of discontinuation of steroids, and the uh, symptom and sign normalize within 10 days to 4 weeks. Medical therapy with 0.5% timolol maleate. is effective during the normalization period, and anicotive acetate injection into the anterior subtenon space in eye with uncontrolled steroid-related ocular hypertension following intravitreal subtenon injection of triamcinolone acetonide is a possible new treatment and is under investigation. And this anticoative acetate is basically an anti-neovascularization agent. Then filtration surgery may be required in intractable cases. Coming to iridocorneal endothelial syndrome, it affects one eye. It is usually seen in middle-aged women, and the clinical spectrum comprises of Chandler syndrome, progressive iris atrophy, and Coogan-Reese syndrome. And the PCR test may reveal the presence of herpes simplex virus DNA in the substantial percentage of eye syndrome corneal and trabecular meshwork specimens, suggesting possible viral etiology. And the mechanism of glaucoma development in all these three syndromes is abnormal corneal endothelial cell layer proliferation and migration across the anterior chamber angle and onto the surface of iris, which may lead to glaucoma development due to trabecular meshwork obstruction by this proliferating tissue, followed by angle closure due to secondary to contraction of this membrane. Now, firstly, coming to Chandler syndrome, it is the most common clinical presentation, and iris changes in this may be minimal to absent. And abnormal corneal endothelial appearance is termed as hammered silver appearance. Coming to progressive iris atrophy, in this the iris features predominate with marked keratoconus, iris atrophy, and ectropy on UVA, and it usually occurs towards the quadrant which is prominent with peripheral anterior synecdoche, and it leads to formation of iris holes which can be of two types. They may be stretch holes which may be caused by traction which occur in a quadrant away from the direction of pupillary displacement, and there may be meat holes which are ischemic in nature and may occur without correctopia. And what is correctopia? Correctopia is when pupil displaces from its normal central position. Now coming to Coogan-Reese syndrome, in this there are nodular or diffuse pigmented lesions of the iris, it is also known as iris nevus syndrome, and it may or may not be associated with corneal edema. Now coming to the management, overall, eye syndrome has a very poor prognosis, but we can proceed with the management in three steps. First, treatment of glaucoma, then treatment of corneal edema, and then treatment of the underlying mechanism. So, coming to treatment of glaucoma can be medical therapy with aqueous suppressant or surgical therapy with trabeculectomy with MMC, glaucoma drainage device, and cyclodestructive procedure. And the treatment of corneal edema can be IOP lowering drugs, hypertonic saline, and PKP in non-responsive cases. The treatment of underlying mechanism is there may be a role of antiviral drugs and immunotoxin drugs, which is still under study. Now coming to glaucoma associated with intraocular tumors, there might be trabecular block, which can be due to angle invasion by a solid iris melanoma, trabecular infiltration by neoplastic cells of iris melanoma, and melanomelitic glaucoma, which occurs in eyes which have iris melanoma. Basically, it occurs due to trabecular blockage by macrophages which have ingested the iris pigment and tumor cells, and it appears similar to phacolytic glaucoma. Then coming to secondary angle closure glaucoma due to ocular tumors, neovascular glaucoma is the most common mechanism in eyes with choroidal melanoma and retinoblastoma. An anterior displacement of iris lens diaphragm may occur in eye with ciliary body melanoma or a large tumor of posterior segment. Now coming to glaucoma secondary to ocular surgery. So post-surgical glaucoma can be divided into glaucoma associated with corneal surgeries, glaucoma associated with epithelial ingrowth, malignant glaucoma, and glaucoma associated with vitreoretinal surgeries. Firstly, glaucoma associated with corneal surgeries, it is further divided into glaucoma after PKP and glaucoma after lamellar keratoplasty. And glaucoma associated with vitreoretinal surgery is divided into glaucoma after pars plana vitrectomy, glaucoma after scleral buckling, and glaucoma after retinal photocoagulation. Now coming to glaucoma associated with corneal surgery, first we will be studying about glaucoma after penetrating keratoplasty. So the glaucoma may develop in early postoperative period or it may develop in the late postoperative period. In early postoperative period, there can be pressure elevating mechanism which are similar to other intraocular procedure, which may be uveal inflammation, intraocular hemorrhages, pupillary block mechanism, and steroid responsiveness. And there may be mechanism which elevate the IOP, which are peculiar to penetrating keratoplasty. And these can be collapse of the trabecular meshwork due to loss of posterior support in aphakic and due to loss of zonal retention, and it may be due to compression of the anterior chamber angle, as the tight suture bites compress the recipient and donor tissue and reduce the length of graft size. Therefore, the compression decreases the condylolimbal angle, which risks the iridocorneal angle collapse and outflow obstruction. Then in late postoperative period, the mechanism can be gradual flattening of the anterior chamber and angle closure in aphakic patient with intact hyaloid phase, and prophylactic vitrectomy should be performed to avoid this complication. In graft rejection cases, the glaucoma can be due to deposition of inflammatory debris over the trabecular meshwork, or there can be epithelial ingrowth or fibrous downgrowth. In pupillary block mechanism, there can be PAS formation and long-term steroid use, or it can be idiopathic. Coming to management, the medical treatment is by beta blocker and prostaglandin analogs in the early postoperative period, which helps to reduce the inflammation, and dorzolamide helps in reducing the endothelial dysfunction and increase the corneal thickness. Then laser therapy, laser PI may be useful in pupillary block glaucoma, laser hyalodotomy in aphakic and pseudophakic malignant glaucoma, and laser iridoplasty to prevent the synovial angle closure. Then surgical therapy may be used, trabeculectomy, glaucoma drainage device, and cyclodestructive procedure in refractory. Coming to glaucoma after lamellar keratoplasty, the mechanism of glaucoma development is pupillary block by air bubble in the immediate postoperative period and steroid-induced glaucoma due to prolonged use. And then the management is medical therapy to lower the IOP and paracentesis to release air in case of pupillary block. So here we can see the air that we have inserted has led to closure of the angle, and it has led to pupillary block, which further leads to increase in IOP. Then coming to glaucoma associated with epithelial ingrowth. So epithelial ingrowth or downgrowth is rare, but it is a potentially blinding complication of anterior segment surgery or trauma. It usually occurs when conjunctival or corneal epithelium cells migrate through a wound and proliferate in the anterior segment. And the elevation of IOP is due to trabecular obstruction by one or more of the epithelial membrane, secondary to synovial angle closure and desquamated epithelial and inflammatory cells. The diagnosis is made by presence of persistent postoperative anterior uveitis, diffuse epithelialization characterized by grayish translucent membrane with a scalloped border that involves the posterior corneal surface in area of surgical or traumatic wound. Cystic and fibrous proliferative patterns sometimes occur and tend to have a better prognosis, and pupillary distortion. Then the treatment comprises of block excision, and which is excision of the adjacent iris and pars plicata of the ciliary body together with all the layers of sclera and cornea in contact with the lesion, and the resultant defect is covered with a tectonic corneoscleral graft. Then we can go with cryotherapy to devitalize the epithelium remaining on the posterior surface of the cornea in the angle and on the ciliary body. We can give intravitreal methotrexate injection 400 mg per 0.1 ml, and we can go with glaucoma drainage device for medically uncontrolled glaucoma with excessive epithelial ingrowth. Coming to malignant glaucoma. So malignant glaucoma is characterized by marked rise in IOP, which is associated with shallow anterior chamber, which occurs after surgery. The alternative terms can be ciliary block glaucoma, aqueous misdirection syndrome, and direct lens block. Also, now there is a specific pathomechanism for which leads to glaucoma development and malignant glaucoma. First is posterior pooling of aqueous. In this, there is aqueous accumulation behind the posterior vitreous detachment, which leads to forward movement of iris lens diaphragm and shallowing of the anterior chamber, and which leads to further angle closure. Then there are three mechanisms. Ciliary block mechanism, which occurs due to anterior rotation of the ciliary body with ciliary processes pressed against the lens, along with anterior displacement of the vitreous, which is responsible for the aqueous misdirection. The anterior displacement of the vitreous puts it in apposition to the ciliary process, contributing to the misdirection. Then there is anterior hyaloid phase block mechanism. This is in this there is intact anterior vitreous phase which is compressed against the ciliary process and breaks in the hyaloid near the vitreous base, allows the aqueous to be diverted posteriorly in the vitreous body and form pockets there. Then there is choroidal expansion mechanism. In this mechanism, it has been suggested that the precipitating event is increase in choroidal volume, which pushes the vitreous body forward, and thus it pushes the iris lens diaphragm or iris vitreous diaphragm forward, which can cause the flattening of the anterior chamber and lead to angle closure. And constantly, the aqueous which cannot move forward collects behind the vitreous, which further moves it forward, carrying the lens and iris further forward with it. Then last is direct lens block angle closure glaucoma. In this, the forward movement of the iris lens diaphragm occurs as a result of laxity of the lens granules, and therefore it may lead to development of glaucoma and increase in IOP. Now coming to the clinical profile symptoms, it usually occurs after an intraocular surgery. That is peripheral iridectomy, filtration surgery, trabeculectomy, and patient develop the following symptoms, which are severe pain in eye associated with headache, nausea, and vomiting and blurred vision. Signs may be flat anterior chamber, raised IOP, negative Siedel's test, absence of pupillary block, confirmed by patent iridectomy, and absence of suprachoroidal hemorrhage. Now coming to the clinical forms, it can be classical malignant glaucoma, it may be aphakic or pseudophakic malignant glaucoma, it may be of other forms, which is meiotic induced malignant glaucoma, which may or may not be present with a prior history of surgery. Malignant glaucoma following laser treatment, laser PI, laser suture lysis after trab or cyclophotocoagulation may lead to glaucoma development. And malignant glaucoma after retinal disease such as ROP, retinal detachment surgery, and CRVO. And spontaneous malignant glaucoma which may occur without any specific cause. The treatment comprises of medical therapy with topical cyclopelagics, which move the iris lens diaphragm back and break the ciliary block, may be done with hyposmotic agents and aqueous suppressants. Laser therapy, argon laser photocoagulation of ciliary process, transscleral diode laser photocoagulation, and ND-YAG laser iridotomies and anterior hyaloidectomy to break the vitreous pockets, to break the aqueous pockets which have been formed in the vitreous body. The surgical measures can be surgical disruption of the anterior hyaloid phase, vitreous aspiration and air injection in the anterior chamber, and pars plana vitrectomy with or without lensectomy. And management of fellow eye should always be done. Prophylactic laser PI should be performed in the fellow eye to prevent further such attacks in future. Now coming to glaucoma associated with vitreoretinal surgeries. So glaucoma after pars plana vitrectomy, the mechanism of glaucoma development can be intravitreal air or gas. It can be secondary open angle glaucoma, glaucoma due to silicon oil, and the last but not the least is neovascular glaucoma, which may occur 2 to 4 weeks after pars plana vitrectomy. So the mechanism of IOP rise in intravitreal air or gas tamponade, the gas that we have injected, which is SF6 and C3F8, they may expand and they may lead to angle closure glaucoma and pupillary block. Then the clinical feature will be sudden IOP rise up to 80 mm of Hg and it occurs on post-op day 1. Management is vitreous tap, medical therapy to lower the IOP and regular IOP monitoring on daily basis. Then secondary open angle glaucoma may manifest after 1 week of surgery and it may be due to red cell glaucoma, inflammatory glaucoma, hemolytic glaucoma, ghost cell glaucoma, pre-existing primary open angle glaucoma. Then comes glaucoma due to silicon oil, which is pupillary block glaucoma, as the oil can block the pupil, and there can be trabecular meshwork blockage by the silicon oil anterior chamber, and which is seen as inverse hypopion or hyperoleon. And the management is inferior palpebral iridectomy, medical therapy, and surgical removal of the silicone oil and placement of glaucoma drainage device. Then there is glaucoma after scleral buckling. The mechanism can be anterior movement of iris lens diaphragm due to raised intravitreal pressure. Second mechanism can be anterior movement of iris lens diaphragm due to anterior rotation of ciliary body, which may lead to choroidal effusion and detachment. Then peripheral anterior synecdoche formation due to prolonged narrowing of the angle. So the take-home message here is secondary glaucomas are preventable cause of irreversible blindness if recognized and treated early. Always identify and address the underlying cause, whether it is lens pathology, inflammation, steroid use, or post-surgical complication. Control of intraocular pressure alone is not enough. Simultaneous management of the precipitating factor is also as crucial as managing the glaucoma. Thank you.